All right. Hi, everyone. Thank you so much for being here. I'm Melissa Goodman. I'm the Executive Director of the Center on Reproductive Health Law and Policy at UCLA Law School. Thank you for taking time out of your busy day for this important discussion that is co-hosted by us and the Mother Infant Cash Coalition. I'm going to kick us off just telling you a little bit of context for this conversation, and then we'll just dive right in. Our center, for those of you who are not more familiar with us, is a think tank and research center developing long-term lasting solutions that advance reproductive justice and address the current national crisis of abortion access. We try to blend long-term strategy work with immediate legal, policy, and research support to advocates, providers, and policymakers. And our center is really committed to advancing the full spectrum of reproductive and family decision-making. And we're particularly interested in the intersection of reproductive and economic justice. Just to ground everybody in this conversation, Sister Song defines reproductive justice as the human right to maintain personal bodily autonomy, to have children, to not have children, and to parent the children we have in safe and sustainable communities. And that is the principle that sort of guides us and guides this conversation. Direct cash programs, which we will talk so much about today, are really rooted in the idea that people have the power to make economic decisions about what's best for their bodies, for their families, and for their communities. And for many people, as many of us know, pregnancy and the first year of having a child causes enormous financial strain. It can be loss of income, significantly increased costs for a host of reasons, the risk of falling into medical debt. And this happens at the same time that there's increased health risks, health appointments, and medical needs, and needs and risks that are not borne equally and often more negatively impact low-income Black and Brown pregnant people. So, in our view, you can't have true reproductive autonomy and reproductive justice if economic barriers alone determine your decision whether to parent or make it possible for you to have a healthy pregnancy or enough financial stability to build a family that thrives. You also don't have true and equal reproductive autonomy or reproductive justice if pregnancy and giving birth makes you 3 times more likely to die, as is true for Black women compared to white women. And it's quite similar for Indigenous women, unfortunately, as well. Now, cash transfer programs are, we think, a promising way to address some of the really stark health and wealth disparities that we have in our country because of structural, racial, gender, and income inequality. And these programs are also a way to achieve what we see as the universal goal that everyone who wants to be a parent should be able to do it and to be healthy along the way. Cash programs can address maternal and infant mortality and other pregnancy health disparities, infant mortality and child health outcomes, which we'll talk a bit about today, potentially the overuse of family separations due to neglect proceedings that result from poverty, and possibly they have the power to disrupt general structural wealth disparities. Now, the state and local innovations that we're seeing in cash transfer programs is very inspiring. It inspired the center to recently, last month, put out its first policy brief on the topic that highlights a lot of the good work you'll hear about today. And those state and local innovations are all the more important given the political realities that we have right now at the federal level. Threats of gutting programs and a social safety net, not just failing to address disparities, but threats to punish programs that do, or research that addresses disparities, and overall, a real deepening of racist and patriarchal power structures and dynamics. So, as we'll talk about today, direct cash transfer programs for pregnant people and new parents have sprung up across the country, and these programs and people evaluating their impact on communities have joined together as the Mother Infant Cash Coalition. And today we will hear from a variety of dedicated and inspiring people who are individuals managing programs or who are part of advocating for the scaled up public investment in unconditional cash transfer programs. And each of these programs is unique. Some are privately funded, some are private and public partnerships. and some are publicly funded. So I'm excited to kick off this conversation. So folks know, if you have questions, you can put them in the Q&A. We will do our best to try to address them, though we have a lot to cover in an hour and 15 minutes. And if we don't cover them, we'll email folks at the end. But with that, I'm going to have everyone introduce themselves, and I'm just going to go in alphabetical order. So Marjorie, I'm going to start with you.
Thank you, Melissa. Good afternoon. My name is Marjorie Gillberg. I'm the CEO of NCJW LA. We are a 116-year-old organization that has been focused on improving the conditions for women and families in Los Angeles for that entire time. But in the past 7 years, we've been specifically focused on centering all of our work and services and our advocacy around direct cash assistance.
Awesome. Thank you. Yuan?
Hi, everyone. Thank you, Melissa, and to the Center for holding this webinar and to hosting all of us. My name is Yuan He. I am a pediatrician, researcher, and public health advocate, and a mom of 2 kids in Philadelphia. And all of that's what makes me really excited to talk to you about Philly Joy Bank, which I help oversee as a child health policy advisor at the Philly Health Department.
Excellent. Thank you so much. Next, we have Zea.
Hi, everybody. Thank you so much for taking the time to hear about our passion projects. My name is Zea Malawa. I am a pediatrician and a public health professional based out of Northern California, specifically Oakland, and I help run the Abundant Birth Project, which is a guaranteed income program that focuses on the entire state of California.
Wonderful. Thank you. All right. I'm going to go to Steph.
Hey folks, Steph Silkowski, she, her director of policy at the Bridge Project, and come to Direct Cash in this work primarily as a policy and advocacy professional. So excited to talk about that angle with you all today.
And Maya.
Good afternoon, everyone. My name is Maya Wolock. I am a research assistant with RX Kids. That's my title, but I wear many hats, including getting to speak to you all today. I'm so excited to talk to you all about RX Kids and its impacts from my background in public health and as a lifelong Michigander.
Awesome. Thank you. All right, we're going to dive in, and you're going to, for folks listening in, you're going to hear presentations from each person about their program and various other things. I'll have some questions for folks, and then hopefully we'll have time to address audience questions. And we are going to start with Abundant Birth Project. So Zea, I'm going to have you kick it off.
Thank you. Okay, let's see. We know it worked a second ago.
Yeah.
Let's see.
We see it.
Okay, and now do you see it in presenter mode?
Now we do, yes. Perfect.
All right. So thanks, everybody. I'm going to start out actually with a quote from one of our participants in LA. So ABP, which stands for Abundant Birth Project, has strengthened me as a mother because it made me feel that there are still people out there who care about the well-being of mothers who may not come from the best background, who genuinely need help and support before, during, and after pregnancy. Because of ABP, I have been able to get plenty of things I needed for myself, for prenatal care, for my baby after birth. So here in California, despite our reputation, we actually have some very wide disparities in who is giving birth early, also known as preterm birth. We define preterm birth as any time a baby is born before 37 weeks of pregnancy. And in California, if you are Black identified, you have a 63% increased risk of having a preterm birth. The March of Dimes put out a paper a couple of years ago, really trying to explore deeply what is driving these disparities in preterm birth. And they really found, after reviewing dozens of articles, that racism is really the primary driver. And so the Abundant Birth Project is really an attempt to make birthing healthy and safe for everybody, regardless of your background. The Abundant Birth Project provides an unconditional guaranteed income during the pregnancy and postpartum period. We started in San Francisco, and we've now expanded to 4 additional California counties. You can see there. And our program provides 18 months of payments in LA County because LA was able to fundraise a little bit more. And in the other counties, we provide 12 months. And so we get to people as early as we can in pregnancy, and then we continue into the postpartum period. Also, the Abundant Birth Project is the very first pregnancy guaranteed income in the country. Just briefly, I have to wear my public health hat for a second to explain why cash and why pregnancy. When babies are born even just a little bit early, it can have lifelong impacts on their development, on their social, emotional growth, on their physical health. And these impacts also might actually lead them to in future have a preterm birth. And so if we can disrupt this cycle while a woman is pregnant, we're not just helping the mother, but we're also creating a healthier future for our entire society. In Canada, back in 2017, they actually studied the income support that they provide automatically to all pregnant people in Manitoba to see what kind of impact it was having. And with a very modest increase in income, they were able to reduce preterm birth by 17.5% and reduce low birth weight by 21%. For those of you all who are not in medicine, I want you to know that these are Ozempic style impacts, right? This is a really big deal. And if cash were a pill, we would have long since invested in it. So at Abundant Birth Project, we kind of are approaching this issue from a pilot to policy model. We started in 150 mamas in San Francisco just to see if it's even possible to do something like this. We started back in 2019 planning this project. We were able to secure seed funding from the state of California through a longstanding advocacy project that ultimately got named the California Momnibus Bill. It was an effort to make sure that doula care is covered by Medi-Cal here in California, but we were also able to get money liberated from the state to help fund pilot programs testing out guaranteed income among pregnant people. We ourselves are trying to test Abundant Birth Project with 950 moms across California, establish this program as an evidence-based model, and then ultimately leverage existing public funding streams to sustain and scale these pilot programs. So far, we've served 850 moms. We've distributed nearly $5.5 million, and we've had 364 abundant babies born. Yay. I got to hold 6 of our graduates back in February, and it was amazing. So as I mentioned, the eligibility criteria right now, in order to join, you have to live in one of these 4 participating California counties. You have to be in the first 2 trimesters of your pregnancy. You have to be over 15 years of age. You have to meet our income requirements, which we set to kind of reach even lower middle class families in each of these counties, but it's based on the different family needs level by county. And then you have to meet one of the top 5 risk factors for preterm birth in California, and those happen to be identifying as a Black person, having had a previous preterm birth, having pre-existing hypertension or diabetes, or having sickle cell anemia. So any of those risk factors qualify. In addition, we recognize that cash is not enough, and so we provide what we call abundance coaching, where we support mamas and meet them where they're at to allow them to access additional services and support. We also have optional research and evaluation because this project is really about learning what works to make birthing safe and healthy for everyone in this country. We have a storytelling pool so that when reporters or funders or other people reach out because they want to understand what this project, how it's impacting parents directly, we have people who have pre-signed up. And then likewise, we understand that this project is not going to be sustained without advocacy. So we also have a policy pool that mamas can optionally join if they want to. As I referenced briefly, I was part of the team that led the effort to have the California Momnibus Bill passed. When this bill passed, it provided funding for diversifying our midwifery workforce in California. It extended pregnancy Medicaid through 12 months postpartum. It started covering full spectrum doula care as a Medicaid benefit. And then lastly, it secured $25 million of state funding for pregnancy guaranteed income pilots. I'll mention that we have public funders for the California Abundant Birth Project expansion listed here. We also have healthcare funders. And then lastly, we have a number of private funders, and all of them have come together to make this project possible. We're so grateful. For those of you who are curious, we also have 3 universities that are part of our research team, UC Berkeley, UC Davis, and the Oregon Health and Science University. This is what we're hoping to learn. We're hoping to learn how cash impacts a mother's mental health, a birthing parent's stress. We're of course curious about prenatal and postnatal outcomes. And then one of the things I'm really excited to learn about is that we are evaluating a birthing person's well-being, hope, and agency as a result of receiving cash throughout the perinatal period. And so I'll end on another quote from one of our parents. It says, "I'm having the healthiest pregnancy after suffering a stillbirth. I'm getting my rainbow baby any day now. And it's all because ABP helped eliminate so much stress with the guaranteed income every month. This is what we want for every single person giving birth in this country. And so I'm really excited to be part of this movement to make birthing safer through cash." Thank you.
Thank you so much. Amazing. I know. I hope this ends up feeling uplifting for some folks. Thank you for that, Zea. We're going to hear next from the Bridge Project. Steph.
Hey folks, just give me 1 second to pull this on up. Can folks see this? Okay. Okay, wonderful. All right. Hi, everyone. Steph Silkowski, Director of Policy at the Bridge Project. The Bridge Project is a direct cash transfer program, like the others that you will be hearing from today, focused on mothers and babies. We launched in New York City in 2021. We now serve over 2,000 babies across 6 states, and have committed over $60 million directly into the hands of pregnant and parenting people. Our model is very simple. We're focused on preventing poverty at its earliest stages, avoiding high cost, high burden program design, and prioritizing dignity above all else. Like you heard from Zea, trust in agency is really important to us. We trust our moms to make the best decisions for themselves and for their babies. We also conduct very robust research and are committed to local, state, and federal policy change with the goal of establishing a federal direct cash program during the perinatal period. And like I'm sure you'll hear from other folks on this call, in our program, we're seeing really promising results, increased savings, movements from transitional to permanent housing, improved mental health, increased workforce participation, and the pursuit of higher education. We really see our model similar to Zea as a catalyst for government action, laying the groundwork for real transformational change. We recognize the limits of philanthropically funded, nonprofit-driven solutions, so we're focused really steadfastly on getting governments to adopt and fund their own Cash for Moms programs. And we're starting with local and state governments, again, with the goal of eventual federal adoption. In New York State, our direct service program has driven both public investment and broader legislative change. We have been really excited to work with the New York City Council to fund and study a cohort of pregnant moms living in shelter and transitional housing. We have also spent the last couple of years pushing for a $250 million bill to establish a statewide publicly funded cash program based on our model. And that bill has gained serious traction. I'll talk a little bit about the strategies that we've utilized to push that. And it's even inspired our governor to propose her own statewide baby allowance program earlier this year. But that work has not been without its challenges and roadblocks. So I want to talk through, some of those challenges that we faced, particularly on the policy and advocacy side of things. And all of these will sound very familiar to folks who have spent their career in advocacy. So the first is, kind of perceived competition with other advocacy efforts. I think particularly for us, some legislators saw our Cash for Moms program, our kind of straight guaranteed income bill, as competing with more familiar child tax credit efforts that had been ongoing for some years. I think like in all of our states, fiscal constraints post-COVID have limited new spending. There are a ton of very outdated welfare narratives and concerns about work disincentives and public perception. Despite New York's progressive reputation, much of the state is very conservative, and so moving skeptics to supporters has been important. And then particularly with, our conversations with government agencies, talking about implementation of these programs as a fully public program, thinking about eligibility verification, payment methods, and data sharing have been, quite complicated at times. And would it have been easier for us to say to our state agencies, like, hey, just contract with us, we know how to do it, we'll handle it all? Sure, but fundamentally for us at Bridge, we believe that the goal is not public-private partnerships. It's a fully public program ensconced in law that can reach more families with more money for longer periods. So we've been able to navigate through those barriers with a few key strategies. The third one I will dwell on the most. So coalition building has been critical. We have built alliances with early childhood and anti-poverty orgs, labor unions, immigrant rights organizations, repro justice groups. Cash for Moms resonates across political and social lines, but we are very, very careful not to align with groups whose broader work might harm our moms. The second point, we do engage in public-private partnerships in the seeking of public funding, not as an end to itself, but as a stepping stone towards more transformational policy change. And thirdly, and my favorite and most importantly, participant organizing. So our moms have been front and center at panels and press conferences and lobby days. It's not me up there. I have not spoken at a single press conference. No one from our team has. I didn't even get an invite to our governor's State of the State address, but our moms did, which was awesome and exactly how it should be. And just last week, one of our moms was the kind of sole speaker and the introducer of the speaker of our city council ahead of her State of the City address. And this mom, Brianna, told her story about overcoming gender-based violence and housing insecurity to a packed house at Lincoln Center. So pretty incredible, really meaningful stuff. And their voices are driving our work and driving this movement. And a lot of that work is happening through a fully compensated advocacy fellowship program where our moms are developing policy skills and becoming spokespeople. They decide entirely what to say and how to say it. Counterintuitively, we don't encourage them to credit Bridge as like their sole reason for their success. They're not lobbying for Bridge, they're lobbying for the policies that they care about, and they're lobbying for more moms to receive unconditional direct cash. And I think removing us from that equation, making us not a necessity to seeing these policies, helps policymakers envision the fully public system that we are trying to build. So what has all that work brought us? So there are now 4 different proposals in New York State for direct cash payments at childbirth. And the likelihood of one passing this spring is very, very high, which is a real testament to the growing political momentum behind this idea. But I think if there's one thing that I hope you take away, it's that cash advocacy isn't happening in isolation. We really stand on the shoulders of past movements from labor rights and civil rights to repro justice and the fight for universal health care. All of this work is grounded in dignity and agency. And like those movements, it's about reshaping systems to empower people, especially pregnant and parenting people, to make the best decisions for themselves and for their families. So with our participants leading the charge, like Brianna here that you see up on stage at Lincoln Center, it does feel like we are really on the brink of something big, a future where direct cash isn't just a policy or a pilot, but a real permanent pillar and a permanent fixture of economic and social justice. And there's a lot of reasons to feel not hopeful these days, but I think in our corner of the world, that future does feel closer than ever. So thanks so much.
Excellent. Thank you so much, Steph. Really appreciate it. All right, we're gonna go to Philly next. Skipping all over the East Coast. Yuan, you're up next.
Perfect. Thank you. And it's such a pleasure going after these amazing women. And I just, as I figure out how to get my slides up. I want to credit both Abundant Birth Project and Bridge for being such inspiring models for our program. So luckily, a lot of what I have planned has already been said by Dr. Malawa and staff. So I'm here to talk about improving birth outcomes through cash through the Philly Joy Bank. And as we like to start with talking about kind of our why, a lot of the themes are going to be similar to what Dr. Malawa mentioned, because this really came out of a desire to address birth equity in Philadelphia. So for those who don't know, Philadelphia is the poorest big city. We've had that unfortunate title for several years now. Of the 10 largest US cities, we have the highest percentage of people living in poverty, so almost a quarter, and over 30% of the city's children live in poverty. And that is in a city where you can see the costs on the right of affording basic needs is about $72,000 per year. We also have disparities, as mentioned by Melissa earlier, where we have Black infants who are 2 times more likely to die than white infants. And you can see the trends to the right showing that as this has changed over time and decreased, that gap continues to be a huge problem. And that is what drives all of our work. So the Philadelphia Community Action Network is a collective impact organization dedicated to reducing racial disparities in infant mortality. And that's the group that led to our work with the Philly Joy Bank. Just to say out loud, hopefully all of you know, but it's racism and not race that is the root cause of these disparities. So Dr. Monica McLemore, who is a renowned Black maternal health researcher, says there is nothing inherent about Black skin that increases risks during pregnancy, except perhaps overexposure to the real culprit, racism, which can harm a mother's body and by therefore a child's body in real measurable ways. At the same time, Philadelphia lacks a lot of the financial safety programs that exist for pregnant people and parents in other parts of the country. So just setting this in a policy context, in addition to decades of structurally problematic policies like redlining, like racial segregation of hospitals and other things that have contributed to worse health outcomes among both moms and babies, we also still lack a state-level child tax credit, state-level earned income tax credit, and paid medical or family leave, all of which we know allows pregnant people to take time off to go to seek medical care during pregnancy, to recover from childbirth, and to bond with their baby, which we know as pediatricians and as researchers are incredibly important for both the mommy's and baby's health. So the nice thing about this is that we have tools to address this. So as a pediatrician, if I see a patient in my office who has strep throat and I know I can use antibiotics to prescribe and address that, what is better to address financial stress and poverty than cash? So through the pandemic, the individual cash payments that were doled out, as well as guaranteed income programs across the country and across the world, have generated a massive amount of evidence showing that cash works to improve birth outcomes and to address child poverty. So with that, we kind of started approaching local philanthropic funders across the city as well as across the country, and we're able to get some city general funds for a public-private partnership to fund our program. And that is how Philly Joy Bank was born. And through our process, we really wanted to emphasize the joy of having a baby and also the expenses of having a baby, especially in a city like Philadelphia, where housing costs continue to be too high for its residents to afford. So I wanted to share our conceptual model because I think one of the policy barriers that we've encountered in conversations is how are we really linking this question between cash and birth outcomes? And you saw some of that outlined earlier in the 2 previous presentations, but this is the way we're thinking about it. And this is also what lays the groundwork for our evaluation. So, you know, through cash guaranteed income, monthly cash transfers, we really believe that by increasing dignity, power, and autonomy of the whole family and improved financial financial stability, we see some of these short-term outcomes. So improved ability to address basic needs for themselves, for their family members, and for the growing infant or fetus, a more supportive environment during the pregnancy and postpartum period, decreased stress overall, which again, we know contributes to a lot of those disparate health outcomes, especially for moms, and improved access to healthcare for both the parent and the child. And through improved parental health and infant health and well-being, we expect to see improved birth outcomes, which has already been demonstrated in other places. So our approach mirrors that of others. We give unconditional $1,000 per month for 18 months, starting in the second trimester of pregnancy. We did a neighborhood-based approach. So we actually looked at, for those of you who don't know, Philadelphia is a city of neighborhoods. So we went and looked for the neighborhoods that have the highest percentages of very low birth weight, which is a proxy for preterm birth, as Dr. Malawa mentioned earlier, to select for those that are at the highest risk of prematurity. And then we actually have a navigator who connects participants with perinatal and financial services that they elect to have. So the perinatal services include everything that's kind of evidence-based to improve outcomes. So doula supports, home visiting supports, we have lactation supports, and we offer those to everyone who applies for the Philly Joy Bank. So even those who aren't selected can access those resources. We also offer financial counseling and benefits counseling, since we want to make sure that all of our participants continue to have access to their public benefits. So what have we learned so far? We have currently just finished enrolling 250 participants. We are still early on in our journey compared to Abundant Birth Project and to the Bridge Project, but preliminarily we are finding certain themes come out in our qualitative work. So things like increased ability to afford basic needs, to have financial stability, increased housing security, which is incredibly important during this period, and increased connections to supports, including social supports of having this cohort of moms to go through this process together. We also found that of the 250 participants that we have, there's a significant amount of housing insecurity and mental health burden. So mental health just being prior mental health problems, substance use problems, things that are causing additional stress during this already stressful time. We also know that community lived experience is incredibly important. So this project was derived from community lived experience with our Community Action Network, and we continue to have people with lived experience as Black birthing people in our specific neighborhoods who can help us build trust, engage in the process, help identify barriers and understand where we might be misstepping, and helping lead the design of our advocacy program moving forward. And finally, collaboration and coalition building. This is why we are here. I think being able to work with and learn from other programs, including those who are on here, but including those who aren't represented here today in the Mother and Infant Cash Coalition, learning from other City of Philadelphia guaranteed income pilots has been amazingly important for us to share resources, share knowledge, and grow our policy goals from there. So I'll end with two quotes from our participants. So these were from our narrative session where folks were asked to take and explain a picture that represented Philly Joy Bank to them. So one person said, usually when my gas tank gets low, I worry I'm not going to be able to make it to work the full week or take my child to events like trunk or treating. To know that I have the money to be able to get gas, I don't have to feel like I'm letting my child down, and I have gas to be able to get to where we need to go. Another person said, being able to get this money helped me sustain the stability so that I can continue affording the 2-bedroom. When I look at this picture, I think of safety and I think of love. Thank you so much.
Awesome. Such a nice note to end us on. Thank you. All right. And I know folks who are listening, I know we're throwing a lot of information at you, and I know there's like a lot of questions in the chat. So just to be clear, we're trying to like kind of give an overview, and then we will dig in a little bit more for some specifics and some of the policy questions people are asking. I am going, where are we traversing throughout the country to next? I believe it's Michigan. All right, Maya, you're up.
Hi everyone. I'm so excited to be here today. Just on a personal level, when I first joined the RX Kids team and I started, writing some of our grants before we even launched, I remember doing such a deep dive into all of your incredible programs and reading so much about you, and it's just such an honor to be here among you today. Um, my name is Maya Wallach, and I am here I'm just going to get my timer up so I don't speak over time. And I'm here to speak about RX Kids and prenatal and infant cash prescriptions. So first, we're going to talk about why cash. Then we'll go over RX Kids design. We'll talk about our impacts. And if there's time, I'll be able to talk about our public-private funding model. So first, why cash? This has been mentioned by so many of our wonderful presenters before, but I just love this graph because I think it really demonstrates how income drops right around the birth of a child. This is also when expenses rise. There's new research that it costs $20,000 to raise a child in their first year of life. And this is also when income is the lowest. So enter child cash benefits. We consider cash benefits to be the evidence-based policy of all evidence-based policies. Um, Over 140 countries have a large-scale child cash benefit program, and the US is not one of them. We were briefly in 2021 with the expanded child tax credit. Many of the people here are familiar with this research, but I just want to highlight that it cut child poverty to an all-time low, reduced food insecurity and hardship, improved health for infants and parents, and reduced the incidence of child abuse and neglect. I say this to really emphasize that cash allows families to raise children in the conditions in which they want to raise children. It allows parents to have the means to be the parents they want to be. And so now I'll go over RX Kids. So RX Kids is the first ever community-wide cash prescription program for pregnant moms and infants. We launched in Flint, Michigan in January 2024. So since January 2024, all moms and all babies within the city of Flint have been eligible for $1,500 during pregnancy and $500 monthly for up to 12 months. Um, this intervention was designed really because of our community partners who told us that this is what they needed. Um, the design uses an approach of targeted universalism, so that means that every pregnant person and newborn in a certain low income place is eligible. Um, there's no income requirement and there are no conditions imposed. That design really allows for there to be very little administrative overhead because when you don't impose conditions and you don't impose requirements, you don't need to pay money to monitor those conditions and requirements. Um, I want to take a second to talk about our values, the framing, and the narrative of RX Kids. On your right, you'll see these two onesies. All moms, when a baby is born in the city of Flint and soon in our expansion communities, receive a personalized welcome package, welcoming their baby to the world with these two adorable onesies, as well as a signed letter from our governor, Governor Gretchen Whitmer, just telling them how excited we are to have you join us here in the world. We do this because we really believe that RX Kids and cash transfers are an example of how we are supposed to care for each other. We want moms to feel that there is a village walking alongside you, that your healthcare providers, that the institutions that surround you believe in you. And we hope that through this, we can help reimagine the social contract. Uh, we want all moms to feel that this program treats them with dignity, enhances their agency, and to really feel that they are loved and that they are deserving of this cash and this help. So I'll move into RX Kids expansion. From the get-go, we've wanted this to be a plug and play program. It has been built to scale. RX Kids has expanded very recently to the city of Kalamazoo in February 2025. And about 11 days ago, we launched in the Eastern Upper Peninsula, which is up here. Um, and that means that 5 counties, Alger, Luce, Mackinac, Schoolcraft, and Chippewa counties are all eligible. Um, because of funding constraints, while we wish that this program could last through all of childhood, we really target the vulnerable periods of uh, prenatal and early infancy. So in our Flint and Kalamazoo programs, we have been able to launch a $1,500 lump sum during pregnancy and then $500 for the first year of life. And then in the Eastern Upper Peninsula, um, we have our program lasting for the 6 months duration. And this is my favorite slide. As of March 11th, we've prescribed over $7 million to 1,800 families and 1,300 beautiful RX Kids babies. Now we'll talk about the impacts that this cash has had. So compared to control groups, zero evictions, there have been zero evictions among our low-income RX Kids moms. We found that they are less likely to owe anything in back rent or back payments on mortgages. Um, and when they do, they owe less. They also have had lower depression scores. And my favorite statistic to ever reach statistical significance is that RX Kids moms have had a greater sense of feeling loved, hopeful, valued, and respected. We also found that moms in the RX Kids programs were more likely to say that they had a greater sense of agency and how to spend household cash. I'll move forward so I have the chance to highlight these quotes from our moms. This first one here, RX Kids helps me to be able to spend present moments loving and nurturing my new baby. It has been able to help me neutralize health issues because of the lack of stress I have in all departments. Another one that I love, I'm now able to get back and forth to the NICU until my daughter is home without hesitation. I can go when I need to because the initial RX Kids payment helped me get another running vehicle. And then finally, RX Kids allowed me to be able to fully breastfeed my baby. These are just a few of the quotes that I'll highlight today really quickly because I don't want to cut into anyone else's time.
We're doing okay, Maya, so I just want you to know you can cover what you want to cover because I know this is
Wonderful.
important.
Wonderful. So RX Kids has had the great pleasure of receiving a historic TANF redirection. We received to date $36.5 million and never been done before redirection of TANF dollars to be used to go directly to direct cash assistance. In Michigan, too many of our TANF dollars have not gone to cash assistance for families in the past. So this is an innovative, transformative program allowing us to use TANF for the cash assistance that it's meant to be used for. Because this happened so recently, it's not even on my slide yet, but on Wednesday, it was announced that the Michigan Senate Democrats unveiled a bill to make RX Kids program expanded statewide. While this still has to go through the budget negotiation process and all of these things, and there will be compromise and et cetera, we are so excited because we believe that this really demonstrates the scalability, the ability of cash to impact moms and impact moms quickly, and how it can be, a really novel way to get the health outcomes that we want to impact. I will move forward very quickly, but I just want to say that RX Kids has been able to use TANF because income drops and expenses rise around the time of birth. We are able to use public funds for all Medicaid eligible folks. And then because of our public-private partnership, we are able to still fund individuals in these low-income areas who are not Medicaid eligible. And we've been able to protect people's benefits. So there are always questions about, what happens to people's SNAP, what happens to people's WIC. We have been able to avoid that and protect all benefits except for SSI, which we are still working on. So I will end with just a hearty thank you to all the other presenters and for you all for taking the time to listen, and thank you so much.
Thank you so much, Maya. And thanks for that kind of introduction of first time of using those federal TANF dollars for such programs. We are, oops, sorry about that. And look, you were under your timer. Marjorie, we are going to you. Last but not least, to LA.
Okay. Do you want to start with the...
Sorry about that. I got
Okay.
distracted.
It's okay.
And excitingly, we're going to show a video
We'll see.
first before Marjorie shares. So Kelsey, if you're able to do the video, we're going to do that for a second. While Kelsey, excellent. While Kelsey is setting it up, I'm just going to remind everyone that our panelists have been great at trying to answer as many questions as possible in the Q&A function. So if you've asked a question, a lot of them have answers. We will try to squeeze in a minute at the end to address any that aren't addressed, though I do have a couple questions for panelists before we get there. Sorry, Kelsey, I was giving you time. We see it and we will soon hear it, we hope. Because Zoom is fun like that. Thanks for bearing with us, everyone.
I'm so sorry. For some reason, it's not sharing my sound the way that it did earlier.
Oh, really? Oh, that's a bummer.
Yeah. All right. It's okay. We don't have to
okay, we'll keep playing with it. Maybe we'll figure out a way.
Yes, maybe I can do it in just a second. Let me keep trying.
Okay.
But we'll have Marjorie, we'll have you go.
Yeah, I'm gonna start.
Try to
it's
do
fine.
it at the end.
That's
okay.
totally fine. Yeah.
Do you mind unsharing your screen though, Kelsey?
I think I can start sharing either way.
Oh, you can? Okay, thanks.
Sure. Zoom smart like that. Too smart. A little too smart for the sound, but
yeah. Sound is always a problem, no matter if you test it. Go ahead, sorry.
Okay. Sorry, I'm trying to get my slide to move. There we go. So National Council of Jewish Women Los Angeles has been providing various forms of cash assistance for more than 15 years. We officially moved into unrestricted cash assistance about 6 years ago. And since then, we've distributed more than $7 million to over 1,000 households in Los Angeles County. To date, all of our pilots have been evaluated formally, and we're committed to contributing to the pool of data that reinforces cash as a critical piece of how we help people in this country. We've also leveraged policy and advocacy to drive our mission. Last year, in coalition with Grace and Child Poverty and a number of other organizations, we had a bill that actually got to the governor's desk. It's a feasibility study bill around guaranteed income, which proposes how to fairly and intentionally assess and decide how and where California state resources should be used to provide the most effective support for Californians. Like other agencies on this webinar, we invite, train, and compensate participants to join us in these efforts at the local and state level. So we also have pilot participants who have come to our lobby days. And again, oh, sorry. Oh, yeah, that's right. I'm sorry. This thing confused me. All right, moving forward. Sorry. All right. So our program is funded, the paid program, which is our pregnancy pilot. We've had other pilots for caregivers. We've done pilots for seniors. We primarily try to focus on women. But this pilot we're one of 7 state sites with the CDSS statewide pilot. We have 364 enrolled moms, and moms to be, and they're in the control and treatment group split evenly. And the program offers $1,000 a month for 18 months to the 182 women enrolled in the treatment. The goals of the program are to reduce acute economic burden on pregnant people who are low income and improve inequities in maternal and infant social, economic, and health outcomes. I don't want to be redundant. So since I knew I was going last, I kind of am going quickly through some of this, but our goals and our outcomes and what we're tracking mirrors a lot of what you've already heard from our partners. My colleagues on this call. So we've repeatedly been told by our research partners that the speed of trust in our pilots is what has made our agency stand out. We've leaned into a very high touch model that begins with our outreach strategies. It continues with one-on-one application support. And another thing that we do that I think, especially in these RCTs, that makes us unique is that we do personal notification upon randomization results. So people who apply and are randomized in our programs don't just get a message on their screen that says they didn't get selected. We actually are on the phone with them or in person with them when the randomization results are shared with them. And these practices have helped us secure an almost 100% opt-in for the control group. So even though, like for the state pilot, we had a delayed launch due to some contract negotiation issues, we were able to reach full enrollment for our program within a matter of weeks because we were able to get people to participate in both control and treatment because, again, that the amount of relationship connection we've built with them even before they're in any part of the program. And I think, Maya, you referenced that everyone's eligible and that you really want, and I think Juan also said you want people to be able to get those services regardless of whether or not they're in the programs. And that's a big part of why we do that. The paid cash supportive services, which are going to appear on the screen now, are available to all participants regardless of whether they're in the treatment or the control group. And some of those, we do mama walks, we do hikes in groups with the moms and babies. They get postpartum kits, mama go bags. We have community baby showers, which is what the video is of. So if we get the video to work, it's very uplifting to kind of see the experience of these community baby showers that also have built-in resource fairs. So there's a lot of interagency connections for the moms. We have a storytelling cohort. We do have a paid advocacy training program specifically to help them learn how to leverage their stories to drive change that helps positively impact their households. They have dedicated support specialists similar to the abundance coaches that Zea mentioned earlier. We also have other services that our organization provides. By the way, we also do photo shoots, maternity photo shoots with the moms. We have other services internally that we offer. So if you're in the paid program, you're eligible for all of our other programs, including our Moms Wellness Network, which is a really amazing supportive space for moms to connect with one another. And it's facilitated professionally, but the content is driven by the folks in the group. And so it's really an interesting and pretty remarkable, powerful opportunity for the moms in the program. We also supplement them with food and vouchers and household goods. For example, we had some moms who were evacuated due to the fires and lost their groceries. And before it was known that SNAP was going to cover the cost of groceries retroactively for anyone who lost groceries, we went ahead and did that for our clients. So our participants received those funds. We also run resale shops around Los Angeles. We have thrift stores there, is the less trendy way of saying it. And so we also provide vouchers if people need clothing or other things for their household. We supplement in that way as well. We also have some moms that have received our rental assistance or qualify for our rental assistance in addition to the monthly payments. And so that's another benefit. And then I was going to end. I had like 2 minutes of video at the beginning, so I have a very short presentation. But with a note that we got from one of the moms who came to one of the showers, and she mentions, I felt all the love today. Growing up in foster care, I don't have much family to celebrate this very special time. I am so grateful for you all. Thank you. Just really, again, I don't know if we're going to be able to share it, but we can, you think? Melissa's shaking. What do you think?
We have a choice. Anyone but Kelsey can share it because we've learned that the person who hits record on the Zoom cannot share audio. So it depends on whether you want to try to fumble with it, or the alternative is after this, we do send an email to all participants with the Zoom recording, and we can include links.
That's fine. We can
so it's up to you.
Yeah, it's fine. We can go into the questions. There's a lot of really meaty questions, I noticed. So I'd like for us to have an opportunity to jump into those.
Okay.
Thanks.
That sounds wonderful. Thank you so much. I'm really so grateful for all of you taking the time to share those details about your programs, and also many of the questions in the Q&A that ask for sort of more detail about, for example, how many months are each of these programs, which departments are you working with, that kind of stuff has been answered in the Q&A. So I'm gonna take, with our limited time that we have left, I'm gonna take us in a couple different directions, but we'll try to weave in themes in the questions as well. One thing that I think a lot of people are really curious about in this moment, and particularly given some of the momentum that you all have talked about in terms of public funding, which I'm going to ask about next. I want to kind of place this in the current moment of what's happening in our country and the world, and just ask some of you, not all of you have to comment on this, but given the attacks we're kind of seeing at the federal level, and things we anticipate with the social safety net and government interventions, especially those that, aimed at addressing race and gender disparities. What do you think of the particular importance of unconditional cash transfer programs in this moment, and how are you thinking about that? I'm not going to make everyone talk about that, but I'm hoping a couple of you will. Does anyone want to dive into that? I don't want to call on anyone.
Okay, I can start.
Awesome.
I'm going to speak specifically about guaranteed income programs during pregnancy and the perinatal period. But I guess one of the things that I think is really important to recognize is that we are trying to operate at what's called a critical window. This is a term that we use in public health to describe a period of time during which if you do an intervention, it's going to have decades-long impact. And so we recognize that both for people who are pregnant and for people who are being gestated, this is a critical window. And so if people are facing incredible stress, incredible hardship, incredible material deprivation during this critical window, that's going to have a decades-long impact. And so the challenges that we are seeing to the social safety net in our administration might only last 4 years, but the impact for the people who are going to be born during this time, it will last for a lifetime. And so I see guaranteed income in this moment as a really important band-aid to actually secure our literal future, right? Because we need the next generation to be born healthy and robust and intact. And so I see that as one of the most important things. I also recognize that guaranteed income is a very specific approach that triages cash to the people who need it most. This is distinct from what Andrew Yang was proposing with a universal basic income where we give it to everybody regardless. With guaranteed income, we really try to triage it to the folks who need it the most to achieve a very specific outcome. And so again, I think in this moment where people who were already marginalized are facing even more oppression, marginalization, and vulnerability, this is a way and an opportunity to kind of cut through a lot of the politics and recognize that people who are giving birth and babies are precious to all of us, and this is how we can honor that.
Thank you so much. Does anyone else want to take that, or should I move on?
I can chime in as well. I think the other piece to say is that many of us know that existing public benefit programs have also often been structured in a way that shuts out certain people. So to call it out, part-time workers, caregivers, which are disproportionately women and people of color in the way that they're set up. And now we're seeing even more attempts to add restrictions or cut funding that, is directed towards those groups. So unconditional cash feels like a way that we can address and sidestep some of those hoops to direct cash towards the group that need it most. And with the flexibility and the nimbleness and the lack of additional administrative burden, those can be direct counters to those proposed strategies. And I'm hoping can pave the way for other benefit programs to also become more cash-like in their administration.
Thank you for that. I'm going to try to take one of the questions I wanted to ask you and combine it with sort of a couple of themes in the Q&A questions. So bear with me a second. One, I think a lot of people are interested in hearing a little bit more detail, sort of about like the sort of the policy momentum that people have faced, but also a little bit about the sort of barriers and pushback. And I think a lot of folks on this webinar are folks, learning about the space for, newly, but also some folks who kind of work in the advocacy space. And I wondered if any of you who spoke about this a little in your presentations would address a tiny bit more, maybe some of the common themes in barriers or pushbacks you hear, and how you've in your campaigns for more public funding or public-private partnerships sort of overcome those things? Then I'll generally ask a question about momentum in a minute. Steph, can I put you on the spot and ask you about that first?
Yeah, I was going to start. I mean, I talked about this a little bit in my presentation, but I think for us in New York, and now that we're in 5 other states, kind of thinking about whether it's replicable elsewhere, there's a lot of perceptions about who our moms are, what they look like, what they sound like, real negative perceptions that are really harmful and ingrained. And as kind of like a white person on our staff, I try to take on as much of that kind of pushback as I can and not put our participants in vulnerable positions, while also building up systems and through our advocacy fellowship, whereby they can be front and center and tell their stories in their own ways, in ways that feel authentic. And so I do think, we would not have seen the successes that we're seeing in New York. We will not continue to see the successes without our moms really leading the charge. And so I think that has been the most important thing for us, is that there is only so much like back end conversations, like agency to agency conversations, things that I can do to move policies forward. I think in every great social justice movement that we've seen in the past, it's been real impacted people directing and leading that work. And so that we really live deeply. And yes, like, is it expensive because we compensate all these moms? Yes. Is it more work because we're training them? Yes. Is it enormously important from both a moral perspective and if you care about actual results? Yes. So I would encourage, anyone who's thinking about, geez, like this is a really tough time to be organizing for direct cash, to, like all of our programs, I feel like we all have an advocacy component and all of us care deeply about participant voice, to continue to invest in your community and in your program participants, because that is like the only way forward.
I want to just tag on a little bit to this. So, yesterday I was talking to a very large social service agency here in Los Angeles that's thinking about piloting a GI program. And even though they're doing, they're talking about it, it's still like a huge frame shift for the team at the CEO level, like even though they want to do it, right? So I think it's interesting when you think about like who's telling their stories. Even people in other social service agencies have certain ideas about the people that they have historically helped that keep showing up in how they are helping them. And so this idea that just to be very specific, they have a homeless program that they were allowed to help people who are unhoused with like some upfront cash that they could pay directly to like a landlord, right? But they couldn't give the money to the person. And so they want to see if it's effective to give the money to the person, not like, and I said to them, but you have to remember, you're not going to control what they do with that money. Like whatever you give them, you're giving it to them so that they have the ability to make a decision about how they want to exist in their world. And there was like that moment, that aha moment of like, oh, wait, how could that possibly work? And it's just that. So even other providers, maybe people on this call, like have some of that skepticism about, can we trust people with these resources? We've always done it for them in this like very patriarchal, racist, like system. Like this is a part of the systemic piece. So I just want to say like, yes, to what you said, Stephanie. And it's not just like policymakers that need to shift their opinions. It's even like our peers who just are not there yet. And so I think it's a lot of that work is the storytelling, but also like peer to peer, like how do we move other agencies to support the policy change that we're asking for?
I'm just going to also answer this. So in addition to the things that my colleagues mentioned, which I think is very true, when we talk about birth in the United States, we can't not talk about racism, especially because Black and Native folks continuously have the worst birth outcomes in the country, and it's not getting better with time. In this wild way, it's actually getting worse. The United States has an outrageously high maternal mortality rate, and it's largely driven because the maternal mortality rates among Native and Black people are so high. But also in this country, we have a real reluctance to acknowledge the presence of racism. And so if we are trying to intervene on a harmful toxin, in this case, racism is the harmful toxin that is harming pregnant people and their babies. When we try to intervene on this, there's a lot of pushback that has nothing to do with research, the medical understanding of this issue, and has everything to do with people's deeply held racist notions. And so I think if we want to become a country where everybody can be born healthy, this is going to be something that we have to overcome. Immediately after the affirmative action decision against UNC was decided in the Supreme Court, our program, Abundant Birth Project, was sued. And to me, this is ridiculous for a number of reasons, but most namely because this is not a question of whether or not you can get into Harvard. This is a question of whether or not you can survive your birthing process intact and whether or not your baby can too. And so this is something that we need to be willing to reckon with in an authentic way, because public health always and consistently targets people on identity factors. This is how we are able to provide the best public health for everybody. So we need to be willing to reckon with the fact that racism is literally harming babies in the womb, and we need to respond accordingly. But there's a lot of reluctance to do that. So that's a major barrier.
Yeah. Thank you to all of you for answering that. And we will definitely stay grounded in that. Thank you so much. In the short time we have left, I want to go back a little bit to some positive momentum that's happening. And Steph, I'm going to put you on the spot first very briefly, but then I'm going to open it up, to others. There's people spoke to sort of the barriers, but a lot of your presentation showed like real progress, right? And momentum and some building kind of desire to explore this and find ways to do it. There's also been some questions in the Q&A about evidence. I just want to say that there's some links in the chat that are going to evidence. The short policy brief that the center put out also has some information about evidence, but one of the big things that's happening is many of these programs are being studied, and part of what MIC, the Mother Infant Cash Coalition, is doing is gathering people together and trying to build sort of a research table and have more research to do things. So Steph, I was hoping you could take a minute to talk about MIC for a second, as Bridge has sort of incubated the start of MIC. And then I want to open it up to other folks to sort of talk about, well, it depends how much time we have left. We might have to go to momentum or something you want people to take away from it, but we'll see how much time we have left. Steph, could you just share a little bit about MIC and sort of also if anybody wants to chime in about the kind of our collective power and how that helps in these situations?
Yeah. It will not surprise you who have heard me in this presentation, like collective action and organizing together and building solidarity is core to Bridges' theory of the case and is essential to ensuring the non-patriarchal, non-racist, fully abundant, safe and healthy future that we want to build. So the Mother Infant Cash Coalition is a project that embodies all of those values. And it's a coalition of program administrators, researchers, policy advocates, representing now, I think, about 26 direct cash programs for pregnant and parenting people in more than 13 states. So you're hearing from some folks today, but there are far more part of that coalition. And really, that coalition is dedicated to advancing the well-being and dignity of families during and after pregnancy, championing inclusive, equitable, and evidence-based cash programs. And as Melissa said, we are working on research, we're attempting to guide policy design for permanent solutions, and really catalyze both systemic policy and narrative change. So in the kind of hopeful future building space, MIC definitely is that place for us at Bridge. It's where we can get together to think about solutions, to build momentum. And I think right now, there is a lot at stake. There's a lot that is incredibly scary. Our program participants are in really dire straits. And I think our programs are all feeling the real necessity of our work. And also, with my political hat on, which is kind of the world that I come out of, this is also an inflection point in many ways. And I think what we have found in New York is that the clarity of message around direct cash, the immediacy with which the impacts are felt is a really fun and amazing thing to organize around. And in this political moment where folks are looking for something that feels real and tangible and hopeful, direct cash, we are finding like is that thing for many people and is cross-cutting. Direct cash, if you are centering real kind of race, economic class differences, is racial justice, is gender justice, is economic justice, and is really simple and fun to organize around. So that is some of the momentum that I feel like I'm feeling, and that is providing me some hope in a very hopeless place.
Thank you, Steph. I'm going to open it up to each of you as we close. I'd love to hear, just one thing you'd love for people to take away from this conversation generally, or in thinking about how we're going to move to a goal of these just being publicly funded or operating programs. I'll go in a random order. Sorry, there's no other way to do it. Maya, do you mind if I call on you first? Something you want people to take away?
Sure. I'd love to. I want people to come away with the idea that cash is not novel. Programs have been operating and implementing change in a meaningful way for years. This is so evidence. I've said it before. This is the evidence-based policy of evidence-based policy. We know there is tons and tons of research that moms are trustworthy, that moms deserve this, and that this is the way to allow moms to have the agency and the healthy backgrounds that they need to raise children and to lead healthy lives of their own. Yeah.
Thank you. Thank you so much. Yuan.
First of all, thank you, Melissa and the Center, and thank you everyone who's taken time to be here today. And I really appreciate a lot of the thoughtful questions that have come through, and I've also learned so much from all of these women. I think for me, especially in this time where there is so much change and uncertainty and chaos, it feels like collective impact is how we're really going to get through. So, in all of these efforts, working together to identify what are our shared values, how do we support each other and empower folks, especially who are being targeted in harmful ways. And cash, we know, is a way that can support everyone. It lifts up whole communities, not just the family that it's given to. And so thinking about that as a rallying cry, as Steph said, hopefully can be a way that we can all bring together partners from all different places to think about how we can support our communities. So again, I think this is like a hopeful way for the future, and hope you all feel this way too.
Thank you. Marjorie, I'm going to go to you.
Thanks. I feel like I want to echo what Maya said, like we know this works. So for those that ask questions about where is the evidence or want reports, you can Google it. There's tons of data on it at this point. It's not about whether or not it works, but I do think it is about how people perceive deservedness and like who should get help. And so when people ask me what they can do, I mean, to me, it's about being part of the shift in perception about why this works, why it's important to do it, why it is ethical. It is critical for supporting families, moms, the future, as Zea said, we're investing in our future as a country. And I think, host a dinner party, bring someone in to talk about it, tell your friends, like that's the thing. I mean, really helping people move from this idea that we have to tell people what they need to do to be helped versus like giving them the resources they need in order to just live equitable lives in this country. I think that, it's about changing perception. So I feel like everyone can play a role.
Awesome. Thank you. And Zea, you get the last word.
I don't know. There's so many things that
No
make
stress. Sorry.
Right? There's so many things that make me hopeful about this. I mean, I love how integrated all of us are into these public agencies. And I love that they're not even mad about that. I love that people are recognizing that medicine can't fix every medical problem. I definitely, as a physician, want to make sure everyone walks away understanding that. And in fact, many of the chronic medical issues that are costing us so much money in this country are actually driven by social factors like poverty, like lack of access, like oppression. And so I think one of the things that makes me most hopeful is that rather than taking a punitive approach with people in this country who haven't had fair opportunities, we are taking a dignity forward approach, one that says that we trust you to know what you need in order to get your life right, in order to start a family, and in order to have that family thrive. And so I think that if we could take a dignity forward approach, not just to cash in the pregnancy period, but just if government could take a dignity forward approach to all of our issues, this country would be such an easier and more pleasant place to live in for all of us. And so I'm inspired that we can lead the way, not only with this innovative intervention, but also with this innovative way of doing it.
Wonderful. Thank you so much. I want to deeply express my gratitude to each of you for taking the time to come and talk with us today, but more importantly, for what you do every day. So thank you. And for everyone who took time out of their busy Friday to listen to this talk and to engage in the Q&A, we're really grateful. We hope this to just be the beginning of the conversation and that you'll see more from all of us, I'm sure, on this topic and also from the center specifically. So thank you so much. We will be sending around the recording and other materials, and we appreciate your time. And unfortunately, our time is up, so I must go. But thank you, everyone. Appreciations. All right. Kelsey, do you mind stopping the recording?